So in the plenary today, Stephanie and I are going to speak for just a short, brief time and give you kind of a initial overview, somewhat of a historic overview of respecting choices, and then we're going to have a panel discussion with our distinguished panel here. From the very beginning, respecting choices has really been focused on one thing: helping organizations and communities keep a promise to the people they serve, which is to know and honor the preferences and the decisions of that individual. For respecting choices, it's never been enough, and it's never been a goal, to simply focus on the completion of written documents or advance directives. We wanted to assure that we knew what the person truly valued and wanted. And then we needed to make sure that what we knew was documented and ultimately honored when these preferences and decisions needed to be made. Keeping this promise demands that we know and understand, first of all, what this person wants. And we believe that this requires, in most cases and at some point, conversations between individuals. And then to create a system where those plans can be stored and made available over time and across setting. And it also means that we educate others to know how to honor these plans. Simply to have the information by a clinician doesn't mean that they're going to use it correctly and use it at the right time. To know and to honor an individual preferences and decisions is really in conformity with the Institute of Medicine's definition of person-centered care. Care that is respectful of and responsive to individual patient preferences, needs, and values, ensuring that the patient's values guide all clinical decisions. This is ultimately what we think knowing and honoring means. Now, this takes a bit of work. It's easy to say this, but we know that this requires at least 4 design elements that have to be coherently and comprehensively tied together. First is system design. We have to have a system that allows clinicians to do this. And then those clinicians have to have interprofessional education, stressing a team approach. Doctors can't do this alone. Nurses can't do this alone. They have to act together as a coordinated team to carry out the design of the system. And as Karen pointed out, we can't have patients coming into this system kind of naive and perhaps even fearful of what this is about. So it requires also community engagement. And Kathy Wurzer last night described a wonderful project demonstrating how that might work. And then ultimately, these systems need to be managed. They need to be managed over time, and they need to be managed using very thoughtful, continuous quality improvement, because none of these systems will just simply function on their own or sustain themselves on their own. So it requires a sustained leadership and tools like quality improvement to make them work. In the beginning, when we started this work in La Crosse, we thought that a facilitator training would provide the workforce that we needed. And today, looking back, we created originally in La Crosse what we now call First Steps. And it was my assumption at that time that if we train people to do first steps, that over time their skills would improve, their competence would increase, their knowledge would grow, and they would then be able to facilitate conversations with sicker patients. This turned out to be false. When Linda Briggs joined the work in 1999, we began to see the data did not justify this assumption. And we realized, as we adopted the PULSE paradigm in La Crosse, that we needed to create another training to help nurses, social workers, and other members of the team to facilitate discussions that would lead to the completion of the PULSE form. And then as Linda and I looked at the data, we realized that this too was not enough, and that there was something in between for patients who had serious illness, but not at the end of life, who needed assistance in thinking about their goals and values and that's how Next Steps came to be. We also realized that we needed to train physicians, and most recently created the shared decision making. So as we did this, we came to a realization that respecting choices needed to be reconceived, and I want Stephanie, who is currently the Deputy Executive Director, but soon to become the Executive Director, to tell us what's next for respecting choices.
Thank you, Bud. So what's next for respecting choices? Well, many of you, is this too loud? It's good? Okay. Many of you are familiar with respecting choices. So what I have the pleasure of talking about is conceptual evolution and how we're describing the work we know that we've always been doing. And so Linda, last night, showed those of you that were here briefly this slide, and I want to use my notes, so I'm doing it well in explaining our conceptual evolution around this work. So this new language, we think, will hopefully excite and inspire you. We've been testing it for the last several months, and those that we use it with immediately want to take it to their senior leaders, their boards, as an engaging, more comprehensive perspective of this work. So person-centered and family-oriented care. There are many characteristics. Some people call these buzzwords, but what do they really mean? So there are many characteristics on how to achieve this, and we believe that one attribute, and some would argue maybe the most important attribute of achieving person-centered and family-oriented care, is person-centered decision-making. And so that is what we are moving to. Instead of just calling this advanced care planning, we're calling this person-centered decision-making as this important attribute. Person-centered decision-making is the active engagement and support of individuals on their journey through the decision-making process. This includes two programs that Respecting Choices offers: advanced care planning, which you are all very familiar with our 25-year history that Bud just talked about. Advanced care planning is to prepare individuals and their families for future healthcare decisions. And you guys all know this language. It's a process of communication and not a one-time event. And it includes reflecting on your goals and values and beliefs, understanding future situations and related decisions, and then learning how to talk to others about these reflections and decisions. So talk to your spiritual advisor, talk to your best friend, talk to your family, talk to your healthcare providers. It's not just talking to one entity, but the community that surrounds you as an individual. And then shared decision-making in serious illness, yeah, there it comes, is to assist individuals with serious illness in making current treatment decisions. It includes a provider, a physician, nurse practitioner, PA, and a patient working together, both contributing equally important information to the decision-making process, both contributing equally to this decision-making process, resulting then in care decisions that align with an individual's goals and values. So together, these programs create an interprofessional, person-centered, and family-oriented approach to engage and support individuals through their decision-making process over time, through illness, and across settings. And to quote Dr. Carol Montgomery, who has joined our team, and we're so thankful for that, she says it's taking our arms and wrapping it around the healthcare team, wrapping their arms around the individual and those that they call family, whoever that may be, to support them on their journey through their lifetime. So what do you think? Like the new language? Good. Yeah, we're excited about it too. If you want to learn more, Carol's having a breakout session about the conceptual evolution, which goes much deeper than this. So now we want to get to the fun stuff of our panel conversation today. So first I'm going to show La Crosse, Wisconsin. So thank you, Karen, for welcoming us to Minnesota. And having some fun with us this morning, but we would be amiss if we don't show a picture of La Crosse, Wisconsin, where this work started. And I have heard Bud and Linda many times call Gundersen Health System their living laboratory for this work, and what a partnership and collaboration it was. And we're very fortunate to have Dr. Jeff Thompson here with us today. And so I'm going to tell you just briefly about Jeff. His resume is so long that it would take the rest of the morning to be able to talk about it. So, so just a few highlights for Dr. Jeff Thompson. He is the Executive Advisor and Chief Executive Officer Emeritus at Gundersen Health System. He is also a pediatrician and author. And I want to pause here. So Jeff has recently authored Lead True, Live Your Values, Build Your People, Inspire Your Community. Isn't that perfect for everybody in this room? It is an exceptional book. Yes, yes. I have read it, and this isn't my copy because I was embarrassed to bring my copy up. It has all kinds of Post-it notes and highlights, and it is just fabulous. And for those of us in the room that are all storytellers and we know the power of storytelling, this is told through stories from so many perspectives, both in and outside of healthcare. And then Jeff will be at the end of the session in the back of the room having complimentary books for you, and he's happy to sign them and answer any questions. There is an opportunity to donate to the Gundersen Foundation within, but he's not charging you guys for these wonderful books today. So thank you, Jeff. So a little bit more, I'm not done talking about Jeff. The other thing, though, I did really want to say is the recognition that Gundersen received, both nationally and internationally, under Jeff's tenure as CEO of that organization. I'm going to go off the bio here. It's just so moving to me. In my work in Iowa, my CEO came and said, Stephanie, have you heard of Jeff Thompson? And I said, no. He said, he's at Gundersen. I said, oh, well, I've heard of Gundersen, because hasn't everybody heard of Gundersen and what they've achieved, both within supporting their community, but also the environment, and just, the holistic picture of health that came under Jeff's leadership. So thank you for that. Then my next picture here is of the Coalition to Transform Advanced Care and the new organization that was created called C-TAK Innovations. So Mr. Tom Koutsoumpas is the co-chair of the board of C-TAK and the president of C-TAK Innovations, and someone who I am so humbled and excited to call my boss. Yes. It is the best experience that I've had from a leadership perspective. The philosophy you have as a leader, Tom, is just exceptional. So Tom is a national leader, again, with a resume that would take all day. So we won't go through that, but I do want to point out that he is leading national experts and advocates in healthcare policy. He's a recognized leader related to issues related to Medicare, elder care, advanced illness, hospice care. Tom helped write the Medicare hospice benefit. It's just, yes, we can thank this gentleman, 1982. It just gave me chills when I learned that, and that we are in the presence of these gentlemen is just amazing. So the mission, you can see, of C-TAK Innovations and C-TAK aligns with this work so well. So the move from Gundersen to C-TAK was very collaborative. It's been a wonderful partnership, and we're really excited to have these gentlemen with us today. So for our panel discussion, I am going to sit and hand a microphone over. And then I'm going to ask just a few questions of Tom and Jeff. Bud's going to contribute his expertise and experience. And then we're going to open it up to you guys. So as I'm asking questions and as they're talking, I want you thinking about your questions. And then there's a microphone in the back of the room. So we'll get to having you go back and have the opportunity. And if you don't have any questions, I have even more. So it's going to be fun. So we're going to start at the regional level, and then we'll move to the national level. So Jeff, I'm going to ask you to share your perspectives with the group as the CEO of a healthcare system who identified person-centered and family-oriented care as the top priority to achieve a culture focused on quality, experience, both patient and clinician, and lowering the cost of care, as Gundersen is well known for in the Dartmouth Atlas data. So my first question for you, Jeff, is how did you elevate the importance of knowing and honoring individual treatment preferences and decisions in all care that was being provided within Gundersen Health System?
Well, thanks for that. And I'll have to be careful with my answers because we have a number of Gundersen staff that are here who actually know the truth rather than what us old guys at the front of the stage say. So thanks for coming and for the invitation. It's lovely. I like the work. This is such important work. It is surprising to me that this should be an outlier rather than the norm. If you walk around the country and you look at the front door, the pillars, the website of most of our healthcare organizations, their values say, take care of the patient first, and it's all about compassion, it's all about the community. It says it all in place. Sorry. The difficulty is implementing that. And I think we get lost sometimes in the complexity of rules and the pressures of minute-to-minute finances. What we said at the board level, at the senior leader level, is that it is a responsibility. We volunteered to be in healthcare. We weren't required to do this. We volunteered. So if we're going to deliver on our promises, then we better get at it. And our promises are to improve the health and well-being of patients and our community. That was our purpose statement. So one of the first things was be really clear about why we exist, what's important. I mean, it's right out of the conversation last night with Kathy and Mr. Kramer. What is your purpose? What are you here for? So you stare the board in the face and say, so what are we really here for? Are we here for the next quarterly operating margin so that we're 3.1 rather than 3.2? No, of course not. We're for the greater good of the community. Great, I'm glad you agree. Here's what the greater good looks like. It means it's about the patients, it's about the community, it's about the well-being. It's one of the brilliance of Bud's work. We didn't start with just Gundersen and make it all right. We started with the breadth of the community and that broad input that was mentioned talking about the common web and those kinds of things. We didn't have all the language, but the function, that's what it was. So the first was go to the board, get them to believe, get them to write down, this is what our purpose is. The next is to inculcate that into our strategic plan and our behavior and our actions all the way through. We had to develop a rhythm in the organization, a palpable feeling that we're here for the good of others. So when you look at the strategic plan of the organization, it didn't say we were going to take over the world for the good of Gundersen. It was all outward facing. It was outward facing, quality through the eyes of the patient, service to patients and families. It stated it on the one-page strategic plan for this billion-dollar organization. It was for the good of the community. What was the financial piece of the strategic plan? Make care more affordable. It wasn't hit a margin, put some money in savings, dominate the water. It was, and growth was the same thing. Growth was to serve the mission. Growth was to serve the mission, not to dominate some geography or something. Really, that's that. I mean, so you get the board to agree, and then you say, what does it look like? It looks like an outward-facing thing. So the common theme is constantly outward-facing. So then it's easier to go to the clinician staff and say, so here's what the mission, the values, the purpose of the organization, the strategic plan, they're all outward-facing. It's the well-being thing. Do I want to make it a great place for you to work as a clinician? You as a clinician? Of course. Do I want to make it a fabulous place for the nursing staff? Yes. But define what fabulous is. It doesn't mean coming in at 10 and going home at 2 with a 2-hour lunch. Here's what fabulous was at our place. It might. Yes, for us old guys, that's what it looks like. But for the people that actually do the work, yeah, it's different. It means work really hard. It works really hard within the construct of a values-based system where the values really matter. Where you have to live those values, you don't have a job. And so it's work hard, live values, serve something bigger than yourself, no one of us, CEO, anybody else, no nurse, no doc, can improve the health and well-being of our whole community on their own. So it's serve something bigger than yourself, and be a part of something that accomplishes things. So when we accomplish things, we focus back in the organization. So when Bud and his team led the community through this work about where we ended up getting over 95% of all of our seniors in the last 2 years of life had plans that were available and that were followed. We would reflect that back onto the staff and say, you did this. You gave people their respect. You allowed, we didn't say the board, we didn't hold the board up and say, oh, what great board members. We said the staff, the people in the trenches talking to the folks honoring their wishes. So you reflect it back.
I want to go to that question next, but I do want to highlight, so Bud talked about the 4 key design elements that many of you are familiar with, but we also talk about the 5th, our first, most important, and that's leadership, right? Well, I think what you just did was you helped us articulate the strategies to ensure leadership takes accountability and is successful at the highest level, starting with the board, including the community. So thank you for tying that system that you're building. Isn't just the workflows, right, but from the highest level. Sure. So the question I want to go to then is the clinicians that you're talking about, Jeff. How did you hold?
They were all perfect, so I had no problem.
Yeah. So those of you in the room from Gundersen, you're good to go.
That's good. Yeah,
you're perfect.
They pretty much say, yeah.
How did you, this is a question I know we hear a lot from folks. How did you define expectations for clinicians and hold healthcare professionals accountable to those expectations? I know in your book you talk about a medical staff compact, yes, that you made, and you held, and it was part of their job responsibilities, and you held it high enough as if you don't do it, it's a medical error. Can you speak to those expectations that you set and what you did if there was pushback? Somebody
Sure.
didn't agree.
Yeah, there might have been somebody that didn't agree. I can't remember, but I'm sure there was someone. Our approach was to say, if we're going to live these values, we're going to aim for this very high thing, we're going to aim for excellence so high that we'll be nationally recognized. Not for the recognition, but that's our goal. Mediocrity wasn't, to measure something and be better than your mediocre peers is not greatness, right? That's just mediocrity with a little plus after it. So we said, what does great look like? Whether it was quality improvement for infections or newborn intensive care work, my work, or with this, we aimed to be better than anyone else. And so that was the theme. Why do you do that? It's for the good of the patients. It isn't for the recognition. But when we got the recognition, we made a fuss about it and said, see, it's not impossible. Here's what the advanced care planning people are doing. Here's what the surgery people are doing. Here's what OBGYN is doing. This is greatness, as good as anybody in the country. So you, orthopedic department, you, internist, you can't tell me we can't do that. So one was to aim for greatness and highlight that. The other is, as we hired people in, an advanced nurse practitioner, an internist, a surgeon, anyone, when you got your application, you got a physician compact that was built by the medical staff and the senior leaders, approved, not a contract. It was a compact. It was a code of conduct, and said, this is what we're going to live. This is how we're going to behave. Here's what Gundersen will give to you. Because remember, holding accountable is important, but that's only a piece of it. If you just hold people accountable, that's it. I can get a little robot with a clipboard and make check marks. Being responsible for their success is much harder. So we put those two together and said, okay, we're going to make sure they behave. Holding accountable is important, but being responsible for people's success. Where are we going? Tell them where we're going, and then clearly give them a chance to succeed. Here's our code of conduct. Here's what we'll deliver to you. Here's what you will deliver to the organization. And in that, what you'll deliver to the organizations, you'll lead on quality and service. You'll treat everyone with respect. You will help measure and make us better. You will lead. That's the expectation. So whether you're the most brilliant neurosurgeon in the country, a family doc going to work in rural Iowa, doesn't matter. same compact, same rules. CEOs, same rules. Administrators, same rules. Here's how we're going to live. Here's how we're going to treat each other every single day. And so that's the expectation coming in. Soon we say, let me see, it's an outward-facing strategic plan. The wishes of the patients are paramount. That doesn't sound too unusual, right? That's outward-facing. It's about the well-being of the patient. The purpose was health and well-being of the patients and community. So we say the patient's wishes are paramount. They'd say, yeah, that's what I bought into. Treating everyone with respect. This is respect for their wishes. It didn't instantly go. I mean, everybody doesn't lean in on it. Some people, doctors, nurses, chaplains, they'd say, nah, I'm thinking this one maybe you don't change. Or they get leaned on by a brother from California. I hadn't seen the mom in 3 years and said, no, she's a fighter. You know, we all know this story. And the daughter says, I've been with her every day for 5 years. This is exactly what she wants. This is what she wrote down. Some places would cave to that brother from California. Yeah, we didn't. We rarely. We almost never caved. We measured it, and we almost never caved. And in fact, if a physician caved to that, then that case would come through physician peer review. A dozen physicians looking at peer review, no different than if I had put a chest tube in the wrong side of a baby that was in extremis, if a surgeon would have had a wound infection, if any other mistaken judgment or procedure happened, it came through. And so then we'd sit with that physician and say, come on, man, what are you thinking? Well, you know, the son was pretty convincing, and he was the CEO of a big health system out there. Doesn't matter. This woman had described her wishes. She had written them down. We'd had multiple conversations. It was absolutely clear. It was available in the record. It's not okay. It's not okay. And so it was a supportive act. So when I talk about living your values, one is the courage to have, the courage to say, here's what my values are and here's how we're going to live. The next is discipline. You have to have it available. One of the things that Respecting Choices get is the discipline to collect the information in an organized fashion. It's one of the reasons why when I've been on stage with Atul Gawande, he and I argue all the time. I mean, I appreciate a lot of the work he does, but he's completely wrong in the idea on a variety of things. We can talk about that later. But and actually, he'd be laughing too because we have great conversations. He's wrong that he thinks that physicians should lead all this work and write down all these conversations. He's just wrong on that. They don't do it well. We've been through that. They make up stuff. They shortcut things. Not that I would ever do that. I'm a pediatrician. I'm an ICU pediatrician. I don't know any rules that I must have followed some rules. I can't remember any. But we had this team that Bud and Linda and the rest of the staff had trained. We had organized stuff. We had common language. We had it available all the time. That gave us so much strength. And then, given that, then we can turn to the staff and say, we're doing everything we can to help you be successful, including supporting hospice, home care, and avenues forward. Right. One last quick story on this. I was in Boston. I was giving a talk about this big named institution up there, and I was talking, and I gave our statistics, and I was quite proud of what the work our staff had done. And a woman came up to me afterward and said, you know, I'm one of the chief medical people here, and I'll have you know, we're up to 90% advanced plans for our people in the last 2 years of life. I said, that's great, congratulations. She said, we follow them 16% of the time.
Yeah.
I said, just like you, yeah, how can I help you? That is so wrong in so many ways. All these people, they believe you are making a promise. And because, well, the doctor this, the nurse this, the chaplain that, we didn't want to invest any money in hospice, home care, something blah, 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 make up a bunch of lame rules or excuses. Our responsibility was to live our values and follow our promises.
Thank you so much. Oh, yeah. Don't you want to clone him and put him in your leadership teams?
My wife's already put a nix on that one. There's no cloning.
So, but I think, one of the important ties to this is that you can't set the expectations until you've built the system to ensure that they can be successful in meeting those expectations. So it's about helping them to be successful once you set the expectations. So thank you for that. Right. So write down your questions for Jeff. We're going to switch to the national perspective.
Thank you.
And ask Tom a couple questions, and then we'll have you guys ask your questions. So thank you, Tom.
Thank you, Stephanie.
For being here with us today and sharing your perspectives as a national leader in policy, social change, and healthcare improvement for those with advanced illness. It's amazing work that you've done. I'd like for you to first just really briefly help everybody understand the relationship between Respecting Choices and C-TAC.
Sure, thank you, and thank you for having me here today. It's a really great honor. As you were talking and I was thinking about all of this, I think when you look around this room, you all are the leaders in the nation driving this. When you're Respecting Choices, Honoring Minnesota, Pulsed, all of the activities that are generating change are driven right here. So I think you all should give yourselves a round of applause to recognize the extraordinary leadership that you all are providing here. It really is exciting. The other thing I was going to say, and Jeff is very humble, I think one of the most important elements of creating change is driven by leadership. And I think leadership in any organization is started at the top by the CEO. And what you did at Gundersen, which really led the nation, was generated by your leadership with the work of your team, but it really goes to you as the leader to make that happen. I think that is a really critical element of all this. So thank you.
Yeah.
Thanks. I just wandered around and gave talks that Bud did all.
Well, it works. It works. And then Bud, and so could I just back up a little bit and talk a little bit about C-TAC, because it may give people a little bit of a better idea about what we're about and how we got started. As Stephanie said, when I was a child, I worked on the Medicare hospice benefit. It was a long time ago, 1982 actually, and I had the good fortune of working with former member of Congress Paul Rogers, who was they used to call Paul Mr. Health. You may remember Paul. He was from Palm Beach, Florida, but he drove Medicare through the House when he was in Congress. He then retired and went to work in private practice, and I had my own personal experience of a loved one that passed away at a very early age with breast cancer. Her name was Marvella Bai. Her husband was Senator Birch Bai from Indiana, and the Bais in my family had grown up together, and I was working on his staff actually, and Marvella was very close to me, and she went through a very difficult period from age 42 to 47. During that period, she fought breast cancer valiantly. She became the spokesperson for the American Cancer Society, and I think was one of the first women to come out publicly and advocate for breast cancer screening. And it really opened the floodgate for others to really talk about it. But she went through a really awful period, and she died at the National Cancer Institute in Washington. And it was the kind of experience that none of us would want to have or want to see a loved one have. So Paul called me after that experience, and Senator Bai was actually leaving office, and said, you know, I've got this really great idea for you, and I'd love to get together with you and talk about something I think you'd be passionate about. He said, there's this thing called hospice that's coming over to the United States. It's from England. It was originated there. And we're doing a number of pilot sites around the nation. And we need to look at it, create a structure, figure out how it should work, and then advocate for it to become part of Medicare. And I was hooked. Within, I think, a day, I was on the team. There were 4 of us with Paul. We actually went to the pilot sites around the nation and visited and learned from each of the sites about what was working and how it should work. And I love to talk about this because when you think about the world today and the healthcare system today, what are we talking about? We're talking about patient and family-centered care, right? We're talking about shared decision-making. We're talking about an interdisciplinary team, not just a physician. We're talking about a nurse-driven initiative, by the way, that includes psychosocial and spiritual support. Now, wait a minute, is this ever going to be in 1982 a part of Medicare? Well, everyone said no. It was not going to work. It would never happen. Fee-for-service was not structured to accommodate this sort of organized approach. And that was ultimately history. With the help of Senator Robert Dole, who was the driving force, we were able to put a structure together, write the first licensure law, create all the elements in the law, including the use of volunteers, the interdisciplinary team, all inclusion of the drugs as well. And I'm very proud of that because it was the beginning of, I think, where we're all going forward with respect to that sort of team care delivery.
Yeah.
So fast forward, President Reagan signed it into law, and hospice has been an important part of our history, and millions of Americans have been the benefit of hospice care. My mother became very ill from 1982, from her age 82 to 87. And she was in Washington. She worked on Capitol Hill in the Capitol and was a well-known person there. She had traveled with Robert Kennedy, and she was very political. And you know, it was hard to watch her go from this vibrant woman to suffering from these multiple chronic conditions. Nonetheless, from age 82 to 87, I called it hell. We were in and out of the ER, and we went to Georgetown University Hospital, or Sibley, which is part of Johns Hopkins. I felt like the ER staff were family. We got to know them so well. We come in, no, you're not gonna scan her again. We can't, well, it's protocol. We gotta do that. And it was just an in and out, in and out, in and out. It was a disaster. So I and my sister had retired from the Hill. She was the head of the Armed Services Committee to care for my mother. And my sister, at one point during the course of the time, and there's a point to all of this, because it gets to caregiving and sort of how we got to C-TAC, she said it was the hardest thing she'd ever done. She landed on helicopters, on aircraft carriers and all of that, but she said nothing was more stressful and difficult than caring for my mom for that period of time. She became ill with an autoimmune disease as a result of it. So she's now an advocate for caregiving, which I'm very proud and excited about. Anyway, so Mom ultimately got into hospice, Capital Caring in Washington, D.C., which is one of the largest community-based not-for-profit programs and was one of the original pilot sites during the demonstration. And it went from chaos to a completely organized, supportive system of care that was just extraordinary. And she ultimately passed away in the care of hospice. We were all there. And it worked the way it should. So that was very exciting from my perspective, that that system worked. But my gosh, what about all this other period? I was at United Health at the time. I was executive vice president there, and I was thinking of leaving United and getting more focused on the issues at hand that I was interested in, Medicare in particular, the elder care, and I thought, well, this is a perfect opportunity. We need to do something about that period of time. I call it the pre-hospice period. You know, you're not gonna get well, you're aging, you're going to decline, but you're certainly not ready for hospice. My mom enjoyed her grandkids and a lively life during that period. So I got together with about 20 people. One of them, who may be in the room, Dr. John Mock, who was the founder of the Evercare program at United Health, who's also with the Hartford Foundation on the board, works with Amy and her team at Hartford. I called John, I called Bill Novelli, who was the CEO at ARP, and we put together about 20 people, the head of Ascension Health System, a home care leader, hospice leader. We all got together in a room for a day, and I identified the problem with the group, and I said, you know, there's a tsunami coming. If you look at the demographics, we are going to be overwhelmed in no time. This is going to overwhelm our entire health system of caring for this population. You add to that, you know, Alzheimer's, the development, the fast development of the number of people with Alzheimer's. What are we gonna do? We've really gotta figure something out here. We've gotta bring the best minds together, and we've gotta all commit to taking this problem on. And we did just that. We spent an entire day together. We went around the room at the end of the day and said to each person and their organizations, are you in? Are you in? Are you in? And to all 20 said, we're completely committed. Many of them competed with each other. And that was one thing that I made very clear, is I said, this problem is bigger than all of us. We can have 25 new companies start, and we're still not gonna be able to take it on. So we need to put our competitive juices aside and commit to take on this national problem. And that's how we started C-TAC.
That's wonderful.
It was an exciting opportunity.
What a brilliant demonstration of collaboration, right?
It really was,
Yeah.
because it allowed people who normally weren't collaborative
Right.
to come together,
Right.
say, problem is bigger than all of us.
Right.
We've got to take it on.
Right.
But more importantly, and when I talk to folks about sort of my philosophy around working in healthcare, I always focus on three things. I say, first of all, what's the most important thing that we need to think about and focus on? What's the most important thing? The patients and families. So if every day you get up and you think about your work and what we're doing, what are we doing today? Mm-hmm. We're thinking about patients and families. Mm-hmm. What's right for them, what supports them, and how do we help them? Mm-hmm. The second thing I like to talk about is helping each other. I think you've really got to foster within your organizations the collaborative spirit of support to each other. How do we make the best and bring out the best in each of us? How do we help you be the best you can be? And that's, I think, a critical part of how we lead and how we get things motivated. And then the third thing, which I think is the most important thing and the simplest thing, every day when you think about what you're doing, do the right thing. If you do the right thing, you won't allow that person not to have their wishes adhered to. If you do the right thing, you'll support the patient and family in their effort. But do we take time to think about that? And I think those are issues that we obviously need to continue to address. C-TAC is now almost 170 national organizations from around the country. We just left our summit in Denver, the first time we had been out of Washington. It was a wonderful success. Many of you were there, and thank you for your participation. We're really on the move, and we can talk more about that, but it's very exciting.
Yeah.
That's how it got started. An idea took off, and here we are.
Thank you. So hopefully that's helpful, because we get questions all the time about what is C-TAC. So Respecting Choices is an affiliate of C-TAC. It's housed in C-TEK Innovations, which we have that up on the slide, which is a new not-for-profit 501c3 that was created as a service delivery arm of C-TAC, because C-TAC's the coalition, it's the collaboration.
Right.
And so we have the program within the service delivery arm. So that helps you to better understand what's happening nationally with the movement that's being created and where Respecting Choices lies.
Right. Could I say one other thing, too,
Please
just
do.
about the way we connected?
Please
So one of the things that we wanted to do when we started C-TAC is we thought we'd divide it into 4 pillars. The first pillar would be clinical model. Develop a clinical model that could be implemented across the nation so that regardless of where you lived, you could have access to the appropriate advanced care support. You know, I like to say, whether you're in New York or whether you're in Terre Haute, Indiana, if your loved one is going through advanced illness, you can access that care. So we created the clinical model, and we based that on the AIM program that Dr. Brad Stewart started at Sutter Health. So we went around looking around the nation and said, what are the best? Let's bring the best together and create the organization around the best.
So can you take that? I think
Sure.
everybody would be really interested in your work on the payment model.
Sure. So we I'm terrible with questions because I go off on these tangents. So we took the AIM model, but we also took we looked at the best telephonic model, and that was compassionate care at the time with Aetna, Dr. Randy Krakauer. But the most important was, where do we look to advanced care planning, and how do we bring the best in? It was a simple and quick decision. It was Respecting Choices at Gundersen. Bud, Linda, the entire team, Jeff. So we immediately connected with Gundersen. Bud became a board member of C-TAC, and that was how we brought the pillars together, which is still the foundation for the work of the organization. We've come a long way. I'm proud to say this year is especially exciting, with the exception of, I do check Twitter on a regular basis to make sure that the Department of Health hasn't been eliminated, or there hasn't been a new, so the first thing I do is check Twitter, and then I start looking at other things and sort of get, you just never know. It's a new life in Washington. But nonetheless, it's still there. And we've had a wonderful, frankly, we had a wonderful interaction with the last administration. The secretary and all the leaders at CMS were very supportive, but they weren't quite far enough along in developing are actually supporting a model, which was, yeah, it takes a long time, right? It's a labor of love, it's a lot of work. I'm proud to say that now, just recently, that the C-TAC, which was established with the health reform law, was a physician-centered group that recommends to the Secretary of Health and Human Services the deployment of new models of care. And a number of models have been presented to the C-TAC. Many of them have not been recommended. I'm really proud to say that the C-TAC model was recommended to the Secretary for piloting across the nation. And I would say, add to that, is that was in conjunction with the work that we've done with the Academy, the AHPM, who was also creating a model. So we had two models being created. They were similar, right, Phil, but not completely the same. And we complementary. But we thought, gosh, during the course of all of this, we thought we should really get together and put these together. So we did. We had a wonderful meeting with the Academy. We had ongoing meetings with CMS, and CMS is now working to implement the Academy C-TAC model for advanced illness. And I think it's going to be coming out probably in the next few months is what we're hoping for.
Oh, so that's wonderful news. We have a vision for the future that would include payment for caring for those with advanced illness, and advanced care planning was included in both the academies as well as C-TAC's mission and vision. Oh, I used my old conceptual language, person-centered decision-making, to include advanced care planning and shared decision-making included in the payment model. So we have high hopes. So if you're not, if you haven't signed up for the C-TAC weekly newsletters, please do. There's tremendous amount of information that's pushed out by their team. Alan is here from C-TAC. He is one of the instigators of getting all of this information out to the nation about what's happening in this space.
Can I do one shout out as well?
Yes, please
to
do.
Amy Berman, who you all heard last night.
Yes.
At one point, Amy and I were visiting, and I love Amy and the Harvard Foundation, and thank you. The Moore Foundation, Stupsky, there's so many, but Amy, we have a very special relationship. But one time we were talking at a meeting, it was at the National Academy of Medicine roundtable, and Amy came up to me during the break and said, you know, the C-TAC model is great, but the Academy model is great. Why aren't you guys working together? And that was the impetus, which said, oh my gosh, this is crazy. We will get together, and that really spurred the
Amy did the same thing
to you. So Phil and I were both approached by Amy, and so thank you for doing that, Amy. That really drove us to where we are today.
Oh, thank you for that. And for those of us that were able to be here last evening, Amy's talk about collaboration, and we just saw evidence of it, was just captivating yesterday evening. So that session was video recorded. All of our plenaries are being video recorded and will be available to you and the public following the conference. So use that information to help inform your leaders within your organization. So thank you, gentlemen. I have no time left. So I made a promise to all of you, I made a promise to all of you that I would save time for you to ask questions, and I broke that promise. So now Jeff is going to hold me accountable, and I'm going to have to go under peer review and probably lose my moderating status. Exactly. So what I would like for you to do is both of these gentlemen have agreed to stay in the room. Jeff is going to go to the back of the room with the tables where his book is available to give to you as well as answer questions. And Tom has agreed to stay up front here for those.
It's a
of you
little
that
unfair.
have
I don't have a
questions.
book to give out. I
But
think
you
the
are-
crowd's all going to be back there.
But you are, yeah.
Oh, okay.
Yeah.
All right. That's a deal.
Perfect, perfect. So to finish this morning's discussion, I want to thank all of you, Bud, for getting us started today, and just for everything. Such a pioneer in this work, and there's going, yeah.
I think Bud only thinks he's going to be retiring. He only thinks he's going to be retiring.
Yeah, Bud is, for those of you that don't know, Bud is moving into a consultant role with Respecting Choices. So he's not leaving us. He's just having more free time to spend with his wife, Barb, and their family. sons and daughters and grandchildren. So, and Tom, thank you for sharing your expertise. Doesn't he belong in Washington, D.C.?
Thank you. I don't know.
If I've,
No, I don't think so.
if I've ever met somebody
Thank
that, just unbelievable. Thank you
feelings
for helping, because those of us that are in the trenches doing this work need people like you to help create and lead these national movements, because it's all supportive from a
We
collaboration.
couldn't do it without you all.
Exactly,
So it really
exactly.
is a wonderful collaboration.
Yeah, and that's been the experience that we've had this month with going to the C-TAC Summit with these national influential leaders, and then our conference with those doing the work, and learning from both groups in how that we need to support and collaborate with each other. So thank you.
Excellent, thank you.
And last but not least, Jeff, thank you so much for sharing your experience. Our entire Respecting Choices team gets questions and wants suggestions about what you led and how you did it. So thank you. Wasn't that just valuable information for you guys? So yes, thank you for your time. And thank you for your generosity and sharing your book with the group. So, and finally, I'd like to say the title of our plenary was Visioning the Future of Person-Centered Care. And I'd like to say, and a shout out and kudos to our team, who's gonna hate me for doing this. Linda showed a team video, or team picture yesterday. I am gonna show one that they are having fun in alignment with Karen's having fun. So that is the Mississippi River behind us in La Crosse, Wisconsin, and we could not vision the future of person-centered care without this team. We're small but mighty, and we are so excited to be partnering and collaborating with all of you moving this work forward. So thanks to our team, and thanks to all of you.